I guess that's a sign for me to start. So, good afternoon, everyone. I'm Ganesh Dhoble. I'm assistant professor of medicine. Been working with the Department of Internal Medicine for the last 1 year. The topic I chose for presenting today is basically preoperative evaluation for patients undergoing non-cardiac surgery, and bulk of the data, the evidence that I'm going to present is going to be based on the 2014 ACC-AHA guidelines. There's also going to be some references to the European Society guidelines, which came around the same time, which were kind of based on analyzing the same data, and pretty much, there are some minor variations, but on most of the points they actually agree on stuff. I have no conflicts of interest, and though I wish I really was not paid anything to do this. So, so the objectives for today's presentation is going to be discussing the national professional guidelines, which are the ACC-AHA guidelines, which kind of have become the standard of care in evaluating a patient preoperatively. Understand the two risk stratification models to use, and what's the difference between them, is one better than the other. Thirdly, understand what's the perioperative management of medication, the beta blockers, the diuretics, the ACE inhibitors, the statins, the antiplatelets, the anticoagulants. And finally, I would talk briefly about preoperative pulmonary assessment. That should cover it. So, why exactly are we worried about postoperative cardiac complications? So, we know from experience that patients undergoing surgery are under kind of a physiologic stress. This kind of gives you a brief idea about the pathophysiology that happens in the pre-op, intra-op, and post-op period, which basically culminates into an increased risk for perioperative myocardial infarctions. So, where do we begin? Well, as in any other evaluating a patient, you start with getting a good history, good physical. Try to identify what's the cardiac risk based on what's the surgical intervention that's planned, what's the risk factor the patient has. Identify those risk factors and try to find a therapy that is going to mitigate those risk factors to either reduce the chance and improve the patient's prognosis. This is kind of the entire flowchart that ACC-AHA came up with. Little bit modifications from the last one that they released in 2007. The main ones were just removing the intermediate risk category from patients' perioperative risk. And now we just have low risk and elevated risk. I'm going to go through, just break it down and go through all these steps and review some of the evidence behind why they recommend what they're recommending. So basically, you start with assessing the patient and trying to see what's the urgency of the surgical intervention. They use the term emergency over here, but what does an emergent surgery mean? And what is an urgent surgery? And probably we haven't heard or we haven't used this term, but what's a time-sensitive surgery? And when do we say that the patient is scheduled for an elective surgery? So this is what they mean when they say that try to assess what's the urgency of the surgery. An emergent surgery is the one in which you think that if the patient doesn't go to the OR immediately within the next 6 hours, there's a risk that he might lose his limb or worse, his life. Urgent is we still have few more hours, but that time is going to be probably dedicated more towards hemodynamic assessment, stabilization, rather than doing any any kind of cardiac preoperative evaluation. And the third category, which kind of we should start using more often, is time sensitive. Now this is something that the patient is relatively stable, but you think that if you go down the route and you end up doing a stress testing that comes back positive and you're going to do some kind of intervention, it's going to delay getting him a surgical intervention, and that's going to have a negative effect on his clinical outcome. So you're basically trying to fix a problem that was not there, and then you're going to end up with a worse clinical outcome. So if you think that the patient is going to have an emergent, urgent, or a time-sensitive indication, that's it. You're done. The patient needs to go to the operating room. There's no further benefit of doing a preoperative cardiac evaluation. it just needs to do a good intraoperative and a postoperative management and follow up on the patient. If the patient doesn't fall into any of these categories, this is when you say that the patient is scheduled for an elective surgery. Elective surgery is a surgery that can be safely deferred for up to 1 year for further cardiac evaluation and management if something's found. Step 2, so you decided that the patient doesn't have any urgent or emergent indication, it's a more of an elective surgery. Then you assess the patient and see if the patient has any kind of acute cardiac syndrome. Now they use the term ACS, but what they're basically referring to is any unstable angina, acute coronary syndrome, any unstable tachy or bradyarrhythmias, decompensated heart failure, and symptomatic valvular heart disease. If the patient has any of these 4 features, you think that this is the one that needs to get priority, this is the one that you should be focusing on managing rather than focusing on a surgical interventions. Try to stabilize the patient in this regards, and then you can think about what's going to be the surgical management of this. So once you decide, evaluate the patient, you think the patient is going to have an elective surgery, he doesn't have any acute cardiac conditions that are going to preclude the surgery, then you move to the next step, which is basically trying to assess what's going to be his MACE. MACE stands for major adverse cardiovascular events. And how do you do that? Now there are basically 2 risk stratification or risk prediction models that the ACC-AHA recommends. One is the RCRI, which we are very familiar with. It stands for Revised Cardiac Risk Index. It is actually kind of a modification to the original cardiac risk index, which was developed by Goldman way back in the 90s. Dr. Lee modified it in 1999, and that's the one that we have been using since then. It has got 6 variables: history of ischemic heart disease, history of congestive heart failure, diabetes which requires insulin, a history of strokes, chronic kidney disease with creatinine about 2, or any patient who's going to undergo a high-risk surgery, which is usually classified as suprarenal vascular, intraperitoneal, or intrathoracic surgeries. Now, based on each of these risk factors has been independently associated with the worst postoperative cardiac outcomes, and when taken in cumulative effect based on the addition of them, the risk just goes up. Down there you can see what's the risk. Basically you're concerned mostly about is the patient going to have less than 1 risk factor or 2 and above. If you have like 1, 0, 1, it's going to be like 0.9%, which is less than 1%, where you start to differentiate between a high risk versus a low risk procedure. If it's more than 2, the next step that you need to do is further evaluation. The second one that is kind of more of a new thing that's coming more into clinical practice is the American College of Surgeons created NSQIP. It's also called the Gupta Index. It's much more extensive. I'll show you a picture. This is the website where you can access the calculator. It's got 21 variables. It gives you information that is specific to the kind of surgical intervention that's planned, which is more of an advantage compared to RCRI. There are plenty of other factors which have been in studies shown to be risk factors but were not included as part of RCRI. Now, the ACS NSQIP was developed using a huge database. It almost studied 500,000 patients. More than 500 centers were involved in creating this thing, and it not only provides you with the chances of patient developing a MACE, but it also provides you with additional information which we don't necessarily get with the RCRI. RCRI is specific only for the cardiac complication, but the NSQIP can provide you with more information on top of the cardiac ones. So how do these two compare with each other? The RCRI was developed as in part of a prospective cohort, 4,000 patients, just one single institution. The data collection was in the late 1980s and late 1990s. So kind of we have moved and come far way ahead since then. The outcomes that they were trying to study was in hospital myocardial infarction, cardiogenic pulmonary edema, VFib, cardiac arrest, and complete heart block. So this is the major adverse cardiovascular event, the risk of which you're trying to calculate. It's a pretty generic risk stratification. Doesn't matter which surgery you're going to undergo. On the other hand, NSQIP is something that has come more recently. It analyzed data which is almost like 100 times more than the RCRI. It's more recent, it was released in 2011. The main outcomes that they were trying to study is myocardial infarction and cardiac arrest, but the follow-up was not just for the in-hospital period. They followed the patient for 30 days post-operatively. So it provides you with more information. Plus, again, the advantage is, you get information that is more specific to that particular surgery. So how do these two risk models compare with each other? Now, C statistic is kind of a biostatistical concept. I'll just give you a rough idea. It is used to compare two studies. 0.5 is when you say that the study is pretty poor. The chance that this was obtained by pure luck is pretty high, and you basically don't rely on those ones. 1 is considered to be ideal, where you say that the risk stratification model is pretty good. 0.7 is where most people draw the line whether the risk stratification model should be used or not. So prospective cohort was used to create the RCRI, and it was validated in the validity cohort, and the C statistic came out to be 0.8, which is a pretty good number, and that's the reason why it became much more prevalent in practice. But later on, when the NSQIP index was developed and they tried to compare it, they did a meta-analysis. There's one that was done by Ford and et al., and another one that was done by Gupta et al., and the C statistic was slightly low at 0.75, which, mind you, is still a pretty good number, but less than what it was presumed to be. The one thing that you should be worried about is the C statistic in patients who are undergoing vascular surgery. Now, vascular surgery is considered to be a special category. Some people were using the 2007 guidelines where vascular surgery by itself used to be an independent criteria about the severity of or the seriousness of the surgical intervention. That's been kind of removed from the 2014 ones, but we know vascular surgery is only next to a cardiac surgery in terms of predicting what's going to be your post-operative cardiac outcomes. So in that particular high-risk surgery, the C statistic is actually pretty close to 0.5. It's 0.59, which makes it less reliable in someone who's going to be scheduled for a vascular surgery. And compared to that, if you look at the NSQIP, it performed much better, 0.8 for all surgeries and 0.74 for vascular surgery. So in terms of head-to-head comparison, NSQIP has performed somewhat better. Now, with all this information, which one to use? Now, the ACC-AHA doesn't really recommend one over the other. It leaves it to the physician's preference, whatever they are more comfortable with. You can use the RCRI. The advantage of RCRI is, it's been around for close to 20 years now. We have gone much more accustomed to using it. There's a level of comfort to it, just like 6 risk indices, and it's something that's been validated previously. The advantage of NSQIP, it's more new. The database that was collected was much more extensive. The information that's provided is more surgery specific. Again, the information was collected in late 2000s, which by that time, there was significant advances in the anesthesia, the perioperative medicine, perioperative cardiacs, and surgical technique, which means this gives you a more realistic picture about what's going to happen recently. Compared to that, RCRI is something that was developed way back in 1980s and 1990s data. But again, as I said, the ACC-AHA doesn't really recommend one over the other so far. So you're basically free to pick and choose one. Just get used to it and try to use it each time you have to perform a perioperative evaluation. Okay, so you picked and choose one risk stratification model. Based on that, you came up with what's going to be a post-operative MACE risk. If you think the number is going to be less than 1%, which means the RCRI was like 0 or 1, you say that the patient is at low risk and he's not going to really benefit from doing any more further workup. What if the patient has elevated risk? That's the thing that's more different compared to the 2007 one. Now you don't really have an intermediate. If it's not low risk, it means it's an elevated risk. So the next thing that you calculate in these patients is something called as the functional capacity. Now, functional capacity is more of a physiological measure of the energy cost of physical activity. It's got a very precise definition. There's a very precise way of measuring it based on your VO2. This will give you a rough idea, but this is not something that is practically possible in most of our patients. So how do you assess someone's functional capacity? So here comes the utility of the Duke Activity Status Index. It's a simple self-administered 12 questions, question answers. You have yes or no answers. This is what it is. Pretty simple, straightforward stuff. Probably would take a couple of minutes for the patients if you can get them to do it. You get the yeses and you add them up, you get a number. There's a mathematical formula, you plug it in, and that at the end of the calculation you get what the functional capacity of the patient is. Now this has been validated and it's proven to be pretty similar to what you get from actually sending the patient to a laboratory to calculate their functionalness. But again, sometimes we are busy, sometimes we don't really have the time to go through this. So there seems to be a more simpler way of trying to assess the functional capacity, something that we use, something we always say, how far can you walk, can you climb a flight of stairs, because that's been validated as well, So what you're trying to find is, does the patient have functional capacity that's more than 4 meds? 4 meds is kind of the magical number in which you feel that, if it's less than that, it's possibly going to be worrisome. But it's going to be, if it's more than that, then probably the patient has got good functional capacity. Most of this comes from studies that show that the stress that's at the general anesthesia or the duration of surgery is going to be putting on your hemodynamic system is around like 3.5 or 3 meds. So if it's 4 meds and above, you think the patient has the hemodynamic capacity to handle the stress of surgery. If it's less than that, then that's something that warrants further workup. Okay, so this is the next step. Good functional capacity, proceed to surgery, you're done, there's no further workup. But some of the patients are either just not able to exert themselves, either because of COPD, either because they have amputations, either because they have strokes, any kind of physiological condition that's going to impair their capacity to exert themselves. That leaves you with a conundrum, like what should be the next step. Now, this is what they recommend. This is where the recommendations start to become more cloudy, in the sense that there's no good body of evidence to recommend one over the other. I'll try to go over some of the evidence that made them decide that this is something we should be doing. So again, if the patient has got poor functional capacity, does it always mean that you should do a cardiac stress testing? It actually does not. They leave it up to the physician's decision. Discuss with the patient and see if doing further stress testing is going to change the management. And with that, they mean that is there an alternative to the procedure? Is the patient going to completely forego the procedure? If we think that there's going to be something and he's going to be at a higher risk for this thing. If the patient says, no, despite whatever my risk is, I'm still going to have a surgery, considering whatever situations are, then basically there's going to be no benefit of doing a stress test. If you decide that you have to do a stress test, they recommend doing a pharmacological stress test. This is just based on the assumption that if the patient was not able to exert at home, probably he's not going to be a very good candidate for exercise stress test. So you do a pharmacological stress test. Now, pharmacological stress test has positive predictive value and negative predictive value. The good part is the negative predictive value has got good correlation with post-operative cardiac complications. So if it's negative, if it's normal, then that's it. It has been shown that it's associated with pretty good prognosis post-operatively, very low chance of developing a major adverse cardiovascular event. If it's positive, that's where it becomes problematic, because it hasn't really been shown to have a very strong association with post-operative MACE. So sure, even if you find an abnormal thing, does that mean that he's going to have a major adverse cardiovascular event? Studies don't really show that. So this is where they say that you should do coronary revascularization according to the existing clinical practice guidelines. I'll go over what this exactly means. Let me talk about this trial, which seems to be the defining trial, or the defining body of evidence that they reviewed before coming with this decision. So this was the preoperative cardiac revascularization study. This was a VA-funded study done way back in 2004. The clinical question that they were trying to answer was, if I have a situation where the patient has high-risk features, if I send the patient to get a revascularization, which would be either doing a PCI, balloon angioplasty, cabbage, doesn't matter, you fix the CAD, is that going to improve his clinical outcome? Because that's what we're trying to get, right? So they randomized 500 patients to either just doing revascularization versus just focusing on doing like optimal medical management, which would be like beta blockers, statins, ACE inhibitors, antiplatelets. And this is what they found. So there was no difference in 30 days in terms of myocardial infarction, strokes, death, reoperations, nothing. Both the study groups were pretty similar. So at 30 days there was really no benefit. They decided to follow the patient. The median follow-up was 2.7 years, but if you look at the actual graph, you can see the follow-up was then close to 5 years, and really, both of them seem pretty head-to-head with each other, which again means that there was really no difference between the two study groups. So bottom line, revascularization did not really improve the clinical outcomes. So this kind of formed the bedrock of why they recommend that probably even if you fix it, it's not really going to change your perioperative cardiac complication risk. So what should we do? Sorry, I forgot about this one. So the CARP study's main criticisms were, they did all these things, but they excluded some of these patients, left main disease, triple vessel disease, ischemic cardiomyopathy. Now this trifecta kind of represents the patients with worst prognosis, the ones who are going to benefit maximum from revascularization, the ones who are going to be at the highest risk for peri-procedural MACE. So this was kind of the big drawback to the study, but even with this limitation taken into fact, this is what showed that even if you revascularize, it's not really going to change your post-operative complication risk. Now reviewing this, what does ACC-AHA have to say? Well, they say, before non-cardiac surgery, if the patient has got an indication to get revascularization, which forget about the surgery, just focus on the patient and his clinical features and his history. If you think despite the surgery he has got indications to get his coronary artery disease fixed, then go ahead and do it, understanding the implication that this is going to delay him getting an operative intervention, and depends upon what kind of procedure he gets. If he gets a bare metal stent, it's going to be at least 30 days. If he gets a drug-eluting stent, it's going to be at least 365 days. If he gets a cabbage, again, that's a whole different story. You have to wait for at least a month before the patient recovers or becomes strong enough to go on another operative intervention. They are very clear that if the only indication that the patient should have a PCI or cabbage is to reduce his post-operative complications, don't do it, because this has been studied and it's been shown to be ineffective. Now again, I would take this with a pinch of salt given the some of the limitations of the CARP trial. But again, if the patient has got triple vessel disease, if the patient has got left main disease, if the patient has ischemic cardiomyopathy, probably revascularization might be a good idea. So far, am I clear? Am I going too fast? Too fast, too slow? No? Okay. So this was the initial part is pretty simple, of deciding whether elective versus non-elective, deciding an acute cardiac syndrome versus non-acute cardiac syndrome, calculating his functional capacity. That's the simple part. This is what you have to understand and remember. If the patient has indications to get a cabbage, irrespective of the surgery, go ahead and do it. But if the patient doesn't have any indication except for reducing perioperative, don't do it. Okay? This is the gist of all that all the ACC-AHA recommends. Second thing, now we think that the patient has got an elevated risk for perioperative MACE. Is there something that we can do about this? Do you think beta blockers are going to help, are going to harm? So this was part of intense evaluation in the last 15-20 years. It basically started with decreased trials. I think people who were practicing back then probably might be aware about these trials. These were European studies done by Dr. Don Paldermans. His name recently became more famous before they had to withdraw all these studies. And the second main trial that was designed to address this question was POISE. Again, a pretty big trial, gave some evidence, which I'm going to go over with. Okay, so let me give you a brief idea about what the decreased trials were, because this was the bulk of clinical evidence, or the main database on which all the recommendations prior to 2014 or say were based on. Decrease 1 came in 1999. It said in high-risk procedures, do perioperative beta blockade with bisoprolol, because it is associated with better outcomes. Decrease 4 said even if the patient is going to for an intermediate risk surgeries, go ahead and do beta blockade with bisoprolol because it's beneficial. Decrease 2 said if the patient is on beta blocker, it's so good that you don't even have to do stress testing. Decrease 5 said if the patient even has a positive stress test, if he's on a perioperative beta blockade, there's really no reason to do revascularization. Now this kind of formed the bedrock of every patient kind of getting beta blockers on preoperatively. But in 2011 there was a huge controversy over these trials when they did an investigation. This was the final report of investigation which ran on for a couple of years. They said most of these trials didn't even have informed consents. Data was not collected per protocol. I think the worst was when they said there was like fabricated data and they willfully submitted untrustworthy data. Don Paldermans was fired. All these studies were withdrawn. On heels of this investigation, this study basically came the POISE trial. Came in 2008, pretty extensive study, 190 centers, 23 countries, almost 8,000 participants. Again, the clinical question was, do beta blockers help in the perioperative and reducing your chances of having a perioperative MACE? So 4,000 people got metoprolol, 4,000 people got placebo. Now the protocol is interesting because what they did was, a couple of hours before an outpatient surgery, they gave patient 100 milligram of metoprolol. Post-operatively, they started giving him 200 milligrams of metoprolol for the next 30 days. What they found was, metoprolol did reduce the risk of perioperative myocardial infarction, but that came at higher rates of bradycardia, hypotension, strokes, and people ended up dying more. So, yes, they found some kind of myocardial infarction benefit, but ended up hurting people more than what they intended to. Criticisms were, starting a high-dose beta blocker just a couple of hours before surgery is probably not the best thing to do. We know that anesthetists, whether it's general anesthesia or opioids, benzos, they all have negative cardiotropic effects. So, starting beta blockers, it's only going to add to hemodynamic instability. So to address this discrepancy between, of course, the withdrawn decreased trials and what we found on the POISE trial, just before the 2014 guidelines were released, they did a meta-analysis of all the available evidence. They removed the whatever decreased trial data was there, and they looked only at the other data. And primarily, all the information was provided by POISE trial, and pretty much they came up with the same conclusions as POISE trial. Beta blocker initiated on the day of surgery was associated with decreased risk of perioperative MI, which came at a higher risk of stroke, hypotension, bradycardia, and unfortunately death. However, if decreased trials are excluded, there isn't really enough data to suggest, if we can do beta blockers, starting a few days to few weeks in advance, and is that going to provide you with some kind of cardiovascular benefit? So on the heels of this, we had the ACC-AHA, which released the 2014 guidelines, and pretty much reflective of what we just said. Don't start beta blockers on the day of surgery. It's a class 3, which means it's a contraindication. It's harmful for the patient. If the patient is on chronic beta blocker therapy, continue during perioperative period. Do not stop that. It's a class 1, which means it's been proven to be beneficial. Okay? These are the 2 things I want you to remember. If the patient is on beta blockers, continue. If the patient is not on beta blockers, don't start it on the day of surgery. This is what the gist of the entire data is. Class 2 recommendations are kind of weaker recommendations, which means it's reasonable to do it, but no one is going to hold you guilty if you don't do it. And these class 2 recommendations came on basis of some meta-analysis that were published in Cochrane, especially trying to figure out what vascular surgeries and patients with high RCRI, do they represent a special subgroup of all these patients who are going to derive benefit from perioperative beta blockade. So they said as long as you do it more than 1 day in advance, possibly more than a couple of days in advance, titrate the beta blockers, start them on a low dose, titrate them to heart rate of 60 to 70, ensuring that they're hemodynamically stable, it should be okay to start them. Again, the level of evidence that we have is not that great. This is more of a subgroup analysis of meta-analysis, which again is not always the best data to rely on. But it should be okay if you do it more than a day in advance. It should be okay if you can do it. Just don't do it on the day of surgery. This was about the beta blockers, but what about the rest of medications? Do you have any beneficial effect? Unfortunately for ACEs and ARBs, which kind of are now the main medication that we recommend for anyone with cardiovascular disease, there hasn't been any randomized controlled trials to evaluate, are they beneficial? Does it make a difference if I start them preoperatively? Is my patient going to live longer, going to have less complications? Most of the information that we have is weaker data, what we say, observational, retrospective studies, and again, that provides you with conflicting evidence. There's like no definitive yes or no. So ACC-AHA says, again, it's a class 2. It might be reasonable. If the patient is taking it, it should be fine up to the day of surgery. Especially in patients with heart failure, it's probably beneficial to control them. If the patient is going to have uncontrolled hypertension, probably it's safe to continue them, because the main thing that we're worried about is intraoperative hypotension. So it should be reasonable to continue them. What about diuretics? ACC-AHA actually does not make any recommendation for or against continuing diuretics. The European Society of Cardiology does say that it should be continued up to the day of surgery, probably held on the morning of surgery and resumed when it's clinically feasible. Again, this is your normal patient who's on diuretics for purely blood pressure control. If the indication is heart failure, then probably the patient should be on it, and you should pay close attention to hemodynamic status and electrolyte levels. Antiplatelets, again, should you stop aspirin, should you stop Plavix? If it's only for primary prevention, probably you can stop it. It's just going to be a matter of few days. It's not going to change a whole lot. But patients who had vascular stents, especially coronary stents being placed in the preceding few weeks to few months, they present a special challenge. Is there a benefit to continue it, or is it harmful to continue it? Is the patient going to bleed? Or if I decide to stop it, is the patient going to have a stent thrombosis, which is usually what you're worried about when you put in a stent. So just combining all the data, this is what the recommendation is. If the patient had a balloon angioplasty, don't operate till 14 days. If the patient had a bare metal stent, do not operate till 30 days. If the patient had drug-eluting stent, if it's a simple elective procedure, probably delay to 365 days. Now again, they do give you some leeway. They say if it's a drug-eluting stent, it's been more than 6 months. The first 6 months are considered to be the ones when the stent is most thrombogenic. Probably after 6 months, it should be safe if you decide to. Again, this is going to be left up to the discretion of the clinician, surgeon, and the patient. Talk to the patient about this is your chance of having a problem with stent thrombosis. This is your risk of having bleeding if you continue on it. And again, what's going to be the comfort level of the operating surgeon? Is he willing to operate on that? So after 6 months, it should be okay. Preferably, you want them to be on drug dual antiplatelets for 365 days. But even if after 6 months, it should be okay if you have to do the procedure. Statin. Now again, I started my presentation about pathophysiology. There was this initial interest in statins, because not just the LDL, they're also known to have anti-inflammatory effects. So does that mean they're going to reduce the chance of having a perioperative cardiovascular event? And they studied that. Decrease 3 was actually one of the withdrawn trials that tried to address this question specifically. They studied this statin, fluostatin, which I don't think we really use it in US that much. But again, it showed benefit, but now it's a withdrawn trial. We don't really have any evidence that says statins are harmful, so there's like no absolute contraindication. Most of the things are, if the patient is on statin, continue it, it's going to be no problem. You can possibly initiate statins in patients who are going to have like high-risk vascular surgeries. Again, level of evidence is not that great, but again, there's like no harm, like, we saw with beta blockers, so it should be okay even if you continue it. It's not going to cause major problems to the patient. Now, anticoagulants. I just wanted to discuss 2 questions. I think atrial fibrillation is the common reason why people are on Coumadin, and what about NOACS in the perioperative period? When do we stop them? When do we start them? This is what the European Society of Cardiology says. Only these patients should actually have bridging anticoagulation if the patient is on Coumadin. And atrial fibrillation with CHADS2 VAS scoring of more than or equal to 4, mechanical prosthetic valves, any newly inserted valve, recent thromboembolism, recent in the sense less than 3 months, thrombophilia, and actually any AFib in which, when the patient had an interruption of his Coumadin therapy, the patient actually ended up having arterial thromboembolism. This is the standing guidelines from the ESC. ACC-AHA is not very for or pro. Now, this was published in 2014. There was one study that came after 2015. I'll just go briefly over this. This was basically to address, patients have a patient with AFib. He's on Coumadin. Does it mean that every time he undergoes any procedure, I have to stop his Coumadin, admit him to the hospital, or get Lovenox, which is an expensive medication? Is there going to be any benefit? Is it going to be any harm? So, just the gist of it was published last year around this time. They compared patients with atrial fibrillation with and without bridging. Mean CHADS2 score, again, CHADS2 scoring was the one that we used to use before the CHADS2 VAS became the more dominant form of the stratification. Mean CHADS2 was 2.3, which is kind of on the lowest side. The outcome was pretty much same in terms of arterial thromboembolism. Both the groups pretty much had the same risk of having a stroke or having a peripheral embolism, what we're worried about. But where the unbridged group had advantage was at the risk of having major bleedings, especially intraoperatively, and showed to be much more superior. So this was just published last year. We don't really have any new guidelines to review it, to reflect this data. But I think when the next time ACC-AHA revises its guidelines, I think this is going to be included in terms of perioperative Coumadin management. If it's going to be really low risk AFib with just like 1 or 2 risk factors, probably it's safe just to avoid the bridging. NOACS, advantage NOACS because short half-lives, so really no reason to worry about bridging. Usually recommended to, most of them will have half-lives around 6 to 11 hours, which means a day or 2 if the NOACS are stopped. By the time the patient comes for surgery, the effect is already worn off, and there's no risk of excessive bleeding. Again, the clearance depends upon the patient's standing renal function, so you have to use that when you decide on discontinuing the NOACS. Again, post-operatively, when do you start it? most of these have very rapid onset of action within within a few hours. So probably it's not safe to start them immediately on day 1 or day 2. Probably it's better to delay starting them for a few days after surgery. Okay, again, this is going to be more of a clinical judgment when you think that the risk for bleeding is something that is acceptable enough. Okay, the last thing I wanted to talk to you about, which is often missed on when we do preoperative evaluation, is pulmonary assessment. The American College of Physicians is the one that came up with these guidelines. Now it's actually been quite a while. This was published way back in 2006. Usually they update guidelines at least every 5 to 6 years. They haven't done that, probably something in the making, but again, this is the last time we have any collection of evidence and study of evidence that we have. So pulmonary wise, you're basically talking about what kind of pulmonary complication is the patient going to have. Are there any risk factors with relation to the patient or the procedure that he's going to undergo, and what can I as a physician do to reduce that risk. These are the main complications. There are many more, but I think these are the main ones that we should be worried about. Not so much with regards to mortality, but mostly about the length of stay, the cost of stay, something that's going to make increase the morbidity of patient in the perioperative period. Atelectasis, pneumonia, prolonged ventilation, respiratory failure, exacerbation of underlying lung disease, which most of the time happens to be either asthma, COPD, or obstructive sleep apnea, and reactive airway disease that gets precipitated during that time. Okay. These are a few of the patient-related risk factors which increase your risk of having pulmonary complications. I've used the odds ratio that comes with it. Age has shown to be a pretty strong risk factor, with the risk increasing for anyone who's above the age 50 and goes up to almost 5.6 times when someone is about 80 years of age. ASA class is the one that anesthesiologists have created and used. ASA1 is a patient who is completely healthy, doesn't have any systemic disease. ASA2 is someone who's got systemic disease, but that is well managed. There's no exacerbation, well-controlled diabetes, well-controlled blood pressure. 3, 4, and 5 are, as the severity of your systemic diseases gets worse. So anyone who's got any systemic disease is going to be at a higher risk for pulmonary complication. Presence of baseline COPD, OSA, functional dependence are independent risk factors. Now, interestingly, if you control obesity for OSA and OHS, it's not actually associated with increased pulmonary complication. Same thing goes for asthma. Okay. So COPD is a risk factor, OSA is a risk factor, well-controlled asthma and obesity adjusted for OSA are not independent risk factors. Surgery-related risk factors, if it's going to be an emergent surgery, if the surgery is going to be prolonged, if the patient is going to be under general anesthesia for all this time, and the main site of surgery, these increase your risk of having pulmonary complications. Now, we went over what patient-related risk factors, what surgery-related risk factors are going to make the patient or may increase the probability of a patient developing pulmonary complications. But does that mean that we need to do more investigations for that? What about doing PFTs? Is PFT warranted? Not really. You can do PFTs, but the whole essence of doing any kind of investigation in medicine is that once you get the results from that, it's going to change your management. They have done studies. FEV1 correlates poorly with any kind of post-operative complications. Patients with even extremely low FEV1s have been able to successfully undergo surgery. There is really no FEV1 level below which you would say that the patient should not undergo surgery. So really, it doesn't really provide you with much of a added information on top of what you know clinically. Secondly, they say that it's probably reasonable to do PFTs if you think there's a patient who's got unexplained dyspnea and you think it's probably respiratory in origin. Similarly, chest X-ray hasn't really shown to change management in terms of your surgical intervention, so probably unless you have a very good reason to do that, not surgery related, probably better to skip it. Now, is there anything that you can do to reduce the risk? Now again, compared to cardiac surgery, this has not really been studied that extensively. We don't really have those robust clinical, randomized clinical trials or meta-analysis. They just, these are more of a generic recommendation. Stop smoking at least 6 to 8 weeks prior. Use incentive spirometry, chest physical therapy if that's available. Treat any underlying acute lung processes like pneumonia. Optimize their lung conditions, which is basically your asthma, COPD, and OSA. If you do that, this is probably the best that you can do to reduce the post-operative complications. Okay, I'll finish this with one last passing mention about obstructive sleep apnea. Now, we know the patient population that we usually see in our institution is struggling with obesity. Not just obesity, most of the times morbid obesity. Now, given its strong association with obesity, there's also been an increased prevalence of obstructive sleep apnea. It is an independent risk factor for both pulmonary and cardiac complications. The basic physiology of loss of upper airway tone, collapse of the upper airway, apneic episodes, hypoxic episodes are just exacerbated by use of opioids, sedatives, anesthetics, neuromuscular blocking agents. So whatever OSA you had to begin with, if it's uncontrolled, it's going to only get worse during the periop period. This is what the American Society for Anesthesiology recommends, that anyone who's got BMI above 30, anyone who's going to have bariatric surgery, higher Malampatti classification to when you examine the upper airway, and anyone who's got history of difficult intubation, we need to screen them. Screening is again pretty simple with the stop bang questionnaire. I think everyone knows about this. We have used it pretty frequently. If you calculate that, it's more than 5, if the patient is considered to be at a high risk for obstructive sleep apnea. So how do you manage that? If the patient has got an established diagnosis, make sure that the patient understands he needs to keep using his CPAP. If the CPAP was just started, give the patient at least 1 to 2 weeks to gain maximum physiologic benefit from CPAP. In the post-operative period, use supplemental oxygen. So oxygen, in the basic physiology of OSA is that you have these apneic episodes, and that results in hypoxemia and hypoxic respiratory failure. So basically giving them supplemental oxygen is just going to delay the development of hypoxemia, though it's not going to correct the apneic episodes. Again, once the patient recovers from general anesthesia and the sedative effects, you can slowly titrate the weaning once the patient is able to maintain the saturations. And again, when the patient goes home, just start them back on the CPAP. This is all that you need to do. Again, this is more of experience-based medicine rather than evidence-based medicine, because we really don't have good clinical trials or good clinical studies to make for or against arguments. So this is more of common sense medical management, which I think should be good enough to manage them. Okay, this is about it. Do you guys have any questions about anything? Stand silence, anything?